So we want to call the meeting to order for the Board of Commissioners for Whidbey Health. Remind everybody that it is being recorded, and we're having minutes taken by Melanie. So again, because we are virtual, people will have to post their questions, and then Jake will monitor those, and we'll basically later on in the meeting, instead of the public comments being the third item, we'll do them later on so that we can acquire a few comments. So that's okay with the board? Move on. Yep. So at this point, I would like to go into the consent agenda. Is there a motion?
Move approval.
Second.
Is there a second? Moved and second. Any discussion? All in favor?
Aye.
Aye.
Say aye. Aye. Raise your hand. Thank you. Basically, you know, it's called to order, and then is there any points of order that we need to bring up? Seeing none, we'll move on, and like I said, we'll hold the general comments for right now. Jake, you're on, right?
I'm on.
You're monitoring them, so okay, we'll come back to you then. So do we have Chris Tumlin on?
I saw him.
I am here.
There he is.
Now we're going to go into the multi-jurisdictional hazard mitigation plan. How's that for an introduction there? Chris,
Yeah,
you're on.
Thank you. I appreciate you guys allowing me the time this afternoon to talk to you about this. Hopefully everybody's received copies of the Island County Multi-Jurisdictional Hazard Mitigation Plan, along with the Whidbey Health Annex. But before we get too far into this, I had some offline discussions with Commissioner Fay regarding some questions that she had with the plan when she was reviewing it. One of the things I need to make sure we discuss, or I'll let you know, is that when we start this plan, this was actually started back in October of 2019. By the time everybody was finished with their annexes and the county was with their plan, it was finally sent to FEMA, I think in June of 2020. From that point, we received a letter back from FEMA that says Region 10 is committed to approving the plan once all of the adoptions from each of the annex have occurred. So in that time frame, there are some things that have changed that are different now than they were when we wrote the plan. And one of the things FEMA understands is that everybody needs to move forward with whatever regulations they have or changes that they have in place. So they understand that when we finally submit the plans, some of it have not been, or some of the elements of the plans have changed because we've had to do that. And they understand that. So what this was giving them was a snapshot in time of where we were at back in when we started the plan back in 2019. So any changes to the plan, they allow for updates, which will be started in, or any changes in the plans will be reflected in the updates that are going to happen. I think that they start another plan back in 2 years from now, I think is when we start the next one. So yeah, so if there were some questions about that, the FEMA understands that things change, that's a snapshot in time. And when I was talking to Bev O'Day from Bridgeview Consulting, she says that typically about 90% of the plans that they write, by the time they are sent to FEMA, they're not 100% accurate. And she said that is absolutely not a problem. So the good news is that the plan that has been submitted is going to be approved by FEMA as long as all of the annexes are adopted. So is there any other questions that anybody may have had about this plan?
That's Aaron.
Next Aaron, somebody.
Chris, I guess my other
Dr.
question would be, is there some mitigating circumstances that will require us to do something and or cost us something? And or is there money forthcoming for it?
This is not, getting the plan approved is certainly not going to cost anything. What this allows us to do is if there is a big natural disaster, and ours, of course, the number one hazard that we have is for earthquakes. So what this plan allows us to do is that, let's say there was a lot of damage from an earthquake, and hopefully we would be able to get funding from FEMA to rebuild the hospital, let's say if something dramatic happens. So what this allows us to do is it allows us to apply for grants in addition to what we may already receive for mitigation purposes, like bringing a facility up to or current like earthquake codes. Let's just say that if they weren't up to code before the disaster, we may get money to build our facility back up to where it was before the disaster. But with this plan, it allows us to apply for additional mitigation grants to not only restore the hospital, but to improve and mitigate for any further disasters that may happen, say from an earthquake.
Thank you.
You're welcome. One of the things I will say is that we, I don't know how many times I've read through this and it's gone to Bridgeview Consulting, is we've identified that there's a couple of spelling errors in there, some grammatical stuff that we are allowed to change prior to sending it back in. They're not big ones, but we are allowed to change those. If we wanted to change anything else in the plan, we would have to start over from scratch. Like if we wanted to remove the part where Whidbey Orthopedic Care is located in Coopville, it's now, I believe, up in Goldie. If we wanted to remove that to say Goldie, we would have to start back at the beginning of the plan again and redo it because our matrix fits into Island County, and it would basically start the process all over again, which would be a substantially financially, it would be bad. It would be bad to have to start this whole thing over again because Bridgeview, they would have to do it all, and Eric is paying Bridgeview Consulting to get this planned. And Eric Brooks is the director of DEM for Island County.
So Chris, do you need a vote of approval for this plan from our board?
That's exactly what I need. Yeah, a vote of approval to adopt this plan so it can go with the overall plan for Island County. And there's other jurisdictions that have to do the same thing. There's Camino Fire, South Whidbey Fire, Town of Coopville, Oak Harbor Fire. Yeah, there's several other entities that are doing the same thing. Once they adopt it, it goes into Eric's plan, and then it's sent off to FEMA. And as long as everything is adopted, then they've already sent us a letter, like I said, for commitment of approval of the plan, which would make us eligible for those grants.
I move we approve the multi-jurisdictional hazard mitigation plan that Chris has presented to us.
Second that.
We have moved and second. Any other discussion?
Chris, I just had a question. So going back to your comment about ortho, if something changes in our system, we change where we provide a service or something along those lines, how does that impact this plan? And you see where I'm going? Do we have to
Yeah, I see where you're going with that, and it doesn't affect the plan because FEMA knows that, especially in healthcare, things are constantly moving. We move a little faster than the federal government does, and they understand that. So as long as it's a part of our Whidbey health system, then it will be covered by the plan.
Any other questions or discussion? Then moved in second to adopt it. All in favor, say aye. Raise your hand. Perfect. Thank you.
Aye.
So moved. Thank you.
Thank you.
Thank you, Chris. Okay, moving on to the medical staff report. Dr. Scheit.
Hi, can everybody hear me?
Yep.
So I have some credentialing for physicians. So our initial appointments, we have Dr. Desai, Dr. Lopez, Dr. Holtz, and Dr. Mann for initial appointments.
Move approval of the initial appointments.
Second.
Moved in second. And all in favor, say aye.
Aye.
Raise your hand. Thank you.
Next is advancements, Dr. Andrew Spitzna, Dr. Kelly Klein for radiology, Dr. Andrew Robbins, radiology, Dr. Kiviat for radiology, Dr. Desai, Dr. Call, Dr. Grant, Dr. Kincaid, Dr. Yu, Dr. Cambron, Dr. Pham, and Dr. Harrison, all from provisional to active for our Skagit radiology.
Move approval of advancements.
Second.
Moved in second. Any discussion? All in favor, raise your hand.
Aye.
So moved. Thank you.
And for reappointments, I have for palliative care, Dr. Ferranato, Dr. Sanders for hospice medical director, and Dr. Thomas Harris for family medicine on courtesy staff for reappointments.
Move approval of reappointments.
Second.
Moved in second. All in favor, raise your hand. Easier.
Aye.
Moved. Thank you.
And on courtesy appointment, Dr. Amy Tomlinson for OB-GYN from locum tenens to courtesy.
Move approval of courtesy appointment.
Second.
All in favor?
Aye.
Raise your hand.
Aye.
Aye.
So moved. Thank you.
And last is Kurt Mueller. He's a physician assistant. He's going to orthopedics provisional for privileges.
Move approval of the additional privileges for PA Mueller.
Second.
Moved in second. All in favor? Raise your hand.
Aye.
Thank you. So moved. Thank you.
All right, and that's my report. Thank you.
Thank you. Moving on to staff and status report from administration. We're going to start with Aaron, our CNO.
There we go. Thank you. Sorry, my apologies for the delay there. I had a little bitty screen that I had to make a lot bigger and find the mute button. So thank you for letting me share with you some updates to our nursing department. So of course, I always like to start talking about vaccines, COVID vaccines, my favorite thing. And when I put this slide together a couple of weeks ago to prepare it, it is now woefully out of date. So it is true, we are serving everyone 16 years and older, but more importantly, we are now serving everyone 12 and older. So we have received FDA authorization to start vaccinating with Pfizer, our younger population. So I'm happy that we had our first few 12 to 15-year-olds coming through our clinic yesterday and were successfully given their first vaccines. So very happy that we're moving into that population. It helps us get back to our new normal a little faster. So we're well over 17,000 vaccines administered at Whidbey Health. In fact, Connor probably can tell us what the official count is today. If he's on, he can share that number with us, but we are looking to transition away from the outpatient vaccine clinic. That's not to say that we will transition away from providing vaccines through Whidbey Health, but we are exploring other options to provide vaccines through our outpatient clinics, and are working on making that transition. So our last first doses will be given the first week in June, and then we will finish out everybody's second doses and move away from the clinic. We've done, this entire community has done such a great job getting folks vaccinated. Last I checked, over 77,000 vaccines have been given in Island County. I'm sure that number is much higher today, probably well over 80,000, so making great progress. We did conduct another pop-up clinic on the south end of the island. I spoke a little bit about this at our board work session. We were planning and eagerly had the volunteers to support about 800 vaccine recipients. Unfortunately, or fortunately, so there's always two ways to look at this. We vaccinated 29 individuals on that vaccine clinic last Saturday. I'm hopeful that means that we are saturating this island with vaccine and that we've gotten almost everybody that's eligible vaccinated. We will go back and get the second doses for those 29 folks on June the 5th. So definitely not quite the turnout that we were hoping for, but it's 29 more vaccines that were given. So probably will not be conducting additional South Island vaccine clinics given the low turnout, but we'll keep things going here at the hospital for a bit longer. I would like to talk a little bit about some leadership changes. So I'm pleased to welcome Adrienne to our team as a nurse supervisor, house supervisor, the other name for the role. So she is joining us. She's actively orienting now. So very happy to have her on board. And then we will be saying a goodbye to Susie, our hospice manager. She is making a change in her career. She's going to help us out though in the vaccine clinic as we finish it out here over May and June. So happy that she's staying on to do that. And just really want to thank her as well as PC and Dr. Sanders. We had a recertification survey for our hospice program last week, and we completed that survey with 0 deficiencies, 0 violations. It was a perfect survey, and the surveyors were thrilled to have worked with our team and to have gone out with our hospice nurses to review the work that they are providing to our community. So it was just, they were so complimentary of our staff, and that's really significant kudos to our leaders in our hospice program. And I also want to, while we're talking about hospice, I do want to offer some appreciation to PC, who is going to step in and serve as interim hospice manager while we recruit a new hospice manager. But what a great way to come into the organization on the heels of a perfect survey. So I'm really excited about the work that they're doing, and Susie, Dr. Sanders, and PC and that whole team get all of the credit for their great work. So then a few other updates of some things that we have recently completed. Installed a LifeLight activation button in our emergency department. So I just would like to offer our thanks to our partner that we have within LifeLight. So this is the bat signal, if you will. As soon as we receive notice that we may need to fly somebody, we can simply hit the alert button that notifies the LifeLight team that we've got somebody that needs a flight out of here, and it bypasses a phone call. It activates the crew very quickly. We've used it successfully several times since its installment, and it's just continues to be a great partnership with LifeLight. I really also want to offer thanks to our birthplace team and Tabitha, who's stepped in as interim manager for Whidbey Family Birthplace, as well as to our phenomenal HIM department. We've worked together to review how non-stress tests are ordered and documented and charged to make sure that we are compliant with that kind of documentation and that our billing practices are in alignment. So that's been a tremendous effort to make sure that we are all working together, and want to thank that team. And then really want to talk a minute about some LACE scoring, which is an index that we can use to predict the likelihood that somebody would be readmitted to the hospital. And so if we score people, we can then take a look at the factors that might cause a readmission and work to provide resources or eliminate barriers to and prevent people from being readmitted. So this was a great work by our care management team to put this scoring in place. Great work by our clinical informatics team to get the scoring tools built into our EMRs. And now we're able to score people and use this data to help make sure that folks have the services that they need before they're discharged and hopefully prevent a readmission. Some great work there. Some things that we are working on. And since this slide was put together, we have completed our, in partnership with ICPH, a survey on childcare services available on the island. So our family birthplace and ICPH partnered with a few other folks to put that survey together for our community. And so now we will be working together to review the results of that survey and then making appropriate plans to help bolster the childcare services that are provided on this island. So another great way that we are partnering with ICPH. Also, I'm very excited about the work that our hospice team and social services are doing together to look at surveying our community about bereavement needs and grief support needs after loss, so that we can conduct a bit of a gap analysis to figure out what services are currently being provided on the island and what services our community most desires, what would help support people. I'm sorry?
No, sorry, my dog.
Oh, so I'm excited that we're working together on developing that survey, and then we'll be administering a survey to better explore how we can support families through loss. And so that work is underway. And then I did mention it the last time, but work continues to grow our spiritual care program. And again, that's work being led by our social services team and Chastity, our resource specialist within that team. So very happy to be putting some time and effort together on that program so that we can, again, support our patients. Other works in progress. So Bert, our trauma coordinator, is participating in a committee, a technical advisory committee, to look at how can we reduce transfer times for patients that need to be transferred after a cerebrovascular accident and do that in a very timely and efficient way. So we have great numbers here at Whidbey Health and are proud of our transfer times and getting people connected with the care that they need. But some of our other rural hospitals are not so lucky to have the efficiency that we have here with getting folks transferred. And so Bert is advising and working within that committee to see if he can help promote cardio or stroke care across the Pacific Northwest. And some work that our HR teams and our surgical services teams are doing that I think is really a novel recruitment approach, and I'm excited that they're working together on these, is to look at operating a recruiting booth at this year's live AORN conference, which is, unfortunately, I have to say, in August in Florida, which doesn't sound ideal, but the conference will be a wonderful one, and I'm excited that our team will go out there to help recruit. We have several needs, staffing needs within surgical services, to include operating room nurses and surgical technologists, and so capturing these folks during the AORN conference would be a great recruitment tool. So excited about the work that's going on there and the partnership that we have with Human Resources. And our pain management committee, I've talked about it before. We had our first meeting. It was a great meeting. We developed some baseline metrics, and we've started collecting on these measures so that we can look at some baseline information about how are we doing with regard to pain management. We're reviewing all of Whidbey Health's policies and procedures around pain management, as well as reviewing all of the latest evidence-based research on pain management for acute, subacute, and chronic pain. And we'll be working together. So it was a phenomenal first meeting. We really accomplished a lot. We approved our charter. We reviewed the program structure and are taking steps to improve the way that we help patients manage pain. So again, great work by that committee led by Dr. Plastino. We're also working on developing some surgical services training. So looking into grow your own approach, which would be a very long-term strategy for recruiting and retaining surgical technicians, working with technical schools across the Pacific Northwest that provide didactic and clinical training for surgical techs. So really working to make sure that we have a constant and steady stream of surgical techs. And then when if they're new and fresh out of school, how can we help ensure their success here at Whidbey Health? So working on a structured program to help orient these folks to their roles if they're fresh out of school. And then looking at how can we partner with some of these other academic institutions. And we are well on the way to our seclusion room in the emergency department. I've mentioned this room, but it's a great tool to help us safely care for patients experiencing behavioral health and substance use disorders, as particularly those of an acute and emergent nature. So a good partnership between the emergency department, facilities, our quality department, and certainly, again, significant thanks to our foundation who helped raise all of the money that we need to develop the seclusion room. So we're in the process of getting bids from a couple of companies that can help us make this room a reality. And then although I don't have time to change the word closure in this slide, we are transitioning away from home care services. We've talked about that before, but I do just want to share with our community how much this organization has appreciated the trust that our patients and our providers have placed in us to allow us to come into their homes and care for them. And we are thrilled to be working with a company like Eden that shares a lot of the same values that we have, and excited that our patients are not going to be left without the care that they very much need. So the transition is happening now, and the home care team is doing a great job to make sure that patients are connected with the services that they need. So just wanted to put that out here, but we've appreciated that trust and are glad that this transition is going very smoothly. And I think that is all that I have.
And Aaron, to answer your question from earlier about vaccine doses, we've currently administered 16,800 and some change vaccine doses to date. All right,
so we're moving right along there, and we have more this week. I think one other thing that's come up since I put my slides together for this presentation is, since we are seeing case counts dropping here in Island County, and we know what the vaccination rate and is looking like in the uptake of vaccine on the island, the executive leadership team met, and certainly after getting feedback from our providers and our staff, and we're making a few changes to our visitor restrictions to ease up on those restrictions a little bit. So beginning today, in fact, we will allow one support person into the facility with a patient. So that's for both the outpatient areas and the inpatient areas. And we certainly are allowing that one support person to stay overnight if they're in a department with a patient that is being housed here overnight and cared for overnight. So that has gone into effect today. And we're certainly hopeful that this will help improve communication and help get loved ones back into the organization so that they can be part of their loved ones' care. It's certainly important to us, and I think it's a good time to start making some small but significant easing on those restrictions. So some good news to share there.
I have a question.
Yes.
Going back to your original slide, when you said that the vaccination program at the hospital will be closing, you mentioned something about looking at clinics taking up that slack if necessary. Is that what you said, or did I misunderstand?
So there certainly will always be, I think, a role for Whidbey Health to play in COVID-19 vaccinations. And so while we may not offer vaccines in the outpatient way that we have been, I think it's going to be important to be able to provide vaccines to our community. So working with Dr. Miller and starting to plan on what that could look like for either our primary care clinics or our walk-in clinics to be able to offer vaccine. We're not very far into this discussion yet, so I don't have much tangible to share about how the logistics of that will work, but those discussions are happening as we look to taper out of the vaccine clinic. I mean, we are at the clinic now seeing about half of the volume that we have been seeing for the last few months. We'll see if there's an uptick with 12 to 15-year-olds being vaccinated now, but we're seeing this not just here at Whidbey Health, but across the island and really across the state. Vaccine has been promoted, and there've been many opportunities to become vaccinated. And so we are seeing the schedule, we are seeing it drop off quite a bit. So it's time to look at our transition and where we move vaccine clinic and the option for vaccines.
Sure, thank you.
Are we seeing 12 to 15-year-olds come down with COVID?
Certainly we have here in Island County had pediatric COVID cases. We're not seeing any hospitalized here at Whidbey Health at the moment, but certainly it is an age group that is able to contract it and has. I think our school districts here have done a very good job of getting folks back into classes and minimizing risk and COVID cases, but nationally that hasn't been true across the nation. We certainly have seen some school outbreaks, but.
How many are we seeing per 100,000 for the general population on Whidbey?
So information from a surveillance report today from Island County, our rate is 89.6 per 100,000, so 90 per 100,000. We were up as high as 135 about 3 or 4 weeks ago per 100,000. So we're definitely seeing a significant decrease. So it's good, but we're not back under the 25 per 100,000 that would indicate that spread is very minimal. So being below 25 per 100,000 is the real goal, but we're headed in the right direction again, finally.
Yeah. Great.
Now, Aaron, going down the road, they're talking about there may be a potential of having to have a booster shot down the road. So is that something when you're having these discussions that, down the road, we may have that whole surge again where all these people that we have vaccinated now, how many of them will be coming back saying, okay, now we got another, 16,000 doses to do boosters? I mean, I just make sure that that's part of your, thought process as we're going forward.
Oh, it's definitely part of the thought process, but there's still more questions than answers around the timing of a booster dose. So, yes.
I want to make sure it's in the column there somewhere.
Me about doing this again.
Is there possibilities of getting titers so that you know if you are protected actually?
And we offer, well, we don't conduct the titer testing here at Whidbey Health, but you certainly can get antibody testing. We can draw antibodies and send that test off for folks. I think one of the challenges, though, still around antibody testing is test positive for antibodies, but we don't know how strong that immune response is or for how long it lasts. So there's still a lot of questions to be answered around even what the utility is in antibody testing and what that information is telling us.
Thank you. Any other questions for Aaron? Moving on, we'll go to quality report. John.
Right, thank you, Commissioner Wallen. So want to give a quick update on several of the things that we're working on. So for the last 5 months, the Med Staff Office has been working on streamlining multiple processes, trying to create a lot more efficiencies from what was there before, and to also better support our providers. We've been working with several of our members of MEC, Michelle Abe, Dr. Pereira, and Dr. Scheidt, on updating Med Staff policies, updating some of the language in the Med Staff bylaws, and basically getting ready for not just D&B compliance, but also just updating what we feel is policies and procedures that are more conducive for med staff to be able to conduct their business. And that has been going extraordinarily well. We are also working right now on streamlining and standardizing our process for onboarding and offboarding of providers, which we are definitely in desperate need of doing. We had a very good development, kind of an unexpected development recently related to med staff services. Right now, those processes that team does is completely manual in terms of credentialing new providers, the way that we facilitate providers basically coming on board our medical staff. A very labor-intensive, time-intensive, and completely analog process. So we have been exploring software that is kind of standard practice across the board for med staff offices to better facilitate, to kind of create a hub in which everyone can work through and be a little bit quicker, be a little bit more on the point for next steps. We landed on a platform called MD Staff that came in relatively cheap, but did a lot of the things that we needed it to do. We were taking that to med staff to ask if they would help us defray some of the costs, if that would even be something that they would be open for discussion on. Not only were they open on it, but they decided to completely cover it from their funds. And that blew me away. It really was not something that we were expecting, but we just, it was an Easter egg, it was a windfall, and I can't thank our med staff enough for stepping up in this way, completely on their own. If we go to the next slide, we are right now continuing to build out data infrastructure or optimize data structures that were existing so that now we're able to get data we just did not have access to before. I was able to show our executive leadership team along the lines of what we've developed to this point. I'll be showing that to members of our QIC in our upcoming meeting. But as a great example of what I'm talking about, anesthesia services, I've asked them to pull some very specific data as part of our joint operating performance metrics. It's a manual process. There's a tracker we created. We were having them pull that data on there. Dr. Kuchek was doing validations and he was doing chart reviews, and it was a sample of like 30 charts. And there's a couple of moving pieces, and we were looking at a snapshot of overall performance. And what we've been able to do since then, rather than look at a snapshot, we can look at every single patient that we would want to carve in to that data set. Basically, any patient who received anesthesia, now we can look at, we can pull together an entire objective picture on how we're doing. There's work that we've done with blood utilization and infection prevention, kind of across the board, that constitutes hours of manual labor that existed before that we're going to be able to remove completely with this new process. It's a time saver, it's an effort saver, and using our platforms and our systems to be force multipliers instead of having to enlist a whole bunch of people to kind of dig through and slog through this work was objective from day one. And we've been able to accomplish quite a bit of that. We are still putting some final touches on some data, and we're going to be transitioning into our outpatient data sets. But so far from looking at what we've been able to produce, the results have been very, very encouraging. This is also the way in which we will track and report on performance improvement initiatives that we'll be doing across the organization. And we're doing that currently with a couple of other things that I'll show you here on the following slides. So if we go to the next one, this is an example of one of our initiatives that are in progress. And it's just one of many. We have quite a few going on. But as we look at this on a monthly basis, we ask each one of these owners report to us current status, what's the step in the process they're taking, what's coming up next, what are barriers we need to be aware of so that we can help you remove those. and basically to ensure that the initiative keeps on moving forward. And if it's not moving forward, why not? Who do we need to talk to? What are the things that we need to do to make sure it's moving forward? The next slide shows an example of an initiative that started and actually has reached a final conclusion. So once these things close out and we start saying, okay, well, we're going to be looking every month on how we're doing and objectively, are we staying on track? That starts to become something that stays on our radar, but fades in the background. We won't spend a whole lot of time relitigating a lot of the things that that brought us to this point, unless it goes off the rails or unless it's not improving to where we expected it to go. But we wanted to create standardization. We wanted to create something easy, but something that also gives us the entire view of where we stand as an organization. We go to the next slide. We've been talking a lot about our patient experience work, and just as a reminder, it's this is more. We look at this as more than an initiative. It's more than a performance improvement project of any kind. I mean, we're. What happened? There we go. We look at this as more of, this is a cultural change. This is the change in how we conduct business. We wanted to be thoughtful. We also wanted to be thorough about this. A lot of times where things lose that staying power is when different folks are running off and trying to solve little isolated parts of the problem instead of the whole thing. In medicine, it's treating the symptoms rather than the causal factor. We've met now 3 times. We just had our last meeting yesterday where we are putting in chronology every step of the things that we're going to need to do to create something sustainable that's a legacy that is carried on for many years going forward. Every new staff coming on board, not just existing staff. So we're estimating and we're hoping to have our planning completed and start working and being able to report that plan to you, and also to start working with our initially identified department by June, by next month. It's a bit of a squeeze, depending on how things go with our D&V survey, which I'll be talking about as well. A lot of that will be contingent on how things pile up in the month of June. But if all things go well, all things considered, we are looking at a June start. Speaking of, and the last thing I'll call out on this one is that our PFAC, Patient Family and Advisory Council, have been very proactive, very interested in working with us on this. We have such an engaged group there. We intend to take full advantage of them. They've graciously offered up their time to partner with us on multiple work breakdowns of this overall initiative. So we are going to graciously accept that offer and integrate them on all these various steps that we start taking. And then the last thing I'll talk about is D&V. We are, our window with D&V is officially opened May 25th. They can show up pretty much any time. It's doubtful, but you never want to, I'm not going to hang my hat on that and put that out as a guarantee, but it's highly doubtful they'll show up in that week, being that close to Memorial Day. We're likely to see them the first part of June. So the first week, second week in June, from insider sources and the rumor mill, it sounds like their survey teams are running on schedule. So we'll probably see them around that time frame. We will be asking our departments over the next several weeks, we'll be messaging this. We'll be asking our departments to ensure that during that time, really limit vacations if we can, of key personnel that can speak very intimately about processes pertinent to that area. We just want to make sure that whenever we're asked those questions, we can give those good answers on the spot. We also have been following up on the internal audit findings. So as you remember, we had about 569 total findings from our internal audits. We have just started to go back and validate that those corrective action plans have taken place and have proven to be effective. We visited several departments yesterday as the latest development in that, and have found that in just about every case, these departments have closed out those findings with good action plans, and they're sustaining them. The staff are enthusiastically engaging with a lot of these corrective action plans as well. Out of the myriad number of findings in each one of these departments, nearly all of them had completely closed out their findings, with the exception of one or two low-hanging items that were still in progress. But I couldn't be more happy with the progress of those departments and how much work that they've done around that. So I think that as we start coming up on our survey window, we really have taken a lot of big steps to be as prepared as we can be. I'm not expecting a clean bill of health on our first survey. I don't think that's a reasonable expectation. Frankly, I'd be a little suspicious if that were to happen. The bar that was set by hospice recently of no findings is a bar no one will ever meet, and we'll never ever see that on a hospital accreditation survey. So I don't want to create an unrealistic expectation. We're likely to see findings, but the goal will be that the findings we do receive, that we already have an awareness of it, we have a plan in action, we're already moving on these things. That is the expectation we're going for. So with that, happy to answer any questions or take any comments if there are any.
Are there any questions of John? Hearing none, thank you, John. Before we go into the IT report, Jake, do you have any public comments or questions that we should address? Or hear,
There were two questions that were asked and answered about why are we transitioning from offering vaccine clinics at the hospital. I think Aaron sent her a direct reply to that, but also responded earlier in the meeting regarding our volumes tapering down and the expanded vaccine providers on the island. The other question was, how does our visitor policy would be held compared to Island Hospital or other nearby hospitals? And Aaron sent a direct response to that. Our policies are similar, have been similar throughout the pandemic. I don't know if you want to address anything specific to that, Aaron, other than what your reply was.
Yeah, I think through a lot of our work with the Hospital Association, WISHA, talking about visitor restrictions across our organizations has been certainly a topic of discussion throughout much of the pandemic. I think we're able to go ahead and move forward with some restriction reductions that other hospitals in other parts of the state are not able to do because they're not seeing the drop in case counts that we are, nor are they seeing the tremendous uptake in vaccine. So, we're not always comparing apples to apples. Being in a more rural setting, less populated area, we feel like we can go ahead and safely move forward with some reduced restrictions. Of course, anybody coming to the facility and not themselves seeking care need to be asymptomatic. They need to have not recently been exposed to COVID-19. They still need to comply with masking mandates and hand hygiene. So there's many things that we can do to help reduce these restrictions, but make sure that we're doing so in a way that is safe. And how do our restrictions compare? Again, I think each hospital's been able to make their own decisions about visitor restrictions, but we look to agencies like the CDC to help guide us in that. And then as we have those talks across the Hospital Association, we've largely done many of the same things. So I can't speak to if Island Hospital has started to reduce restrictions. When a couple of weeks ago, I don't believe they had. I don't know if they've made any changes. Certainly their case counts, although I don't know what they are today, like I do for Island County, including Skagit County, they probably have slightly higher case rates. So they may not be ready to make any reductions yet, but I can't really speak to that. But
I think that's an important point, Aaron, that we do base our restrictions based off of CDC guidelines and not what any other hospital may or may not be doing. So it's probably interesting to note what other hospitals are doing, but we probably wouldn't necessarily have an impact on what our policies are per se as we're following the CDC guidance.
But we do share best practices across hospitals, and we've seen that throughout the pandemic across the nation, how willing hospitals that maybe have once been seen as competitors were willing to share best practices, and visitor restrictions and visitor policies are no exception to that. So we are all in some ways working together, but in many ways still working very independently, and case counts are a significant factor.
So Ron, we have other questions that have come in, and I don't know until I don't know if there was a designated time in the meeting for public comment.
Is there something that you think we ought to know about now, or you want to do it later in the meeting?
Well, I can continue to push them forward. There was a question about.
I suggest that we wait till the end of the meeting. Why don't we get through the regular business and then go to the questions?
Okay.
Okay, that sounds good too. Okay. Well, then we'll move on to our IT report. Brett, are you there?
I'm here. I don't have a PowerPoint slide today, so I'm just going to summarize the activities in IT very simply for you. To give you a soundbite, really what we're focusing on, what we've been focusing on since I came on board back in December, is really getting back to basics in IT in order to be able to have a foundation that will allow us to do much bigger things in the years and months ahead. So I would summarize everything that we're doing right now into 4 buckets. Our staffing migration, our insourcing of staffing and building out of a new staff, security and compliance related initiatives, system management, and I'll explain that in a minute, and processes and process improvement. So from a staffing standpoint, we've discussed in the past the fact that we are insourcing our IT department. And of course, we're going through the work right now of identifying and vetting qualified candidates to build out this new department, and things seem to be progressing well so far. There's a lot that we have to do. It's going to be a bit of a journey, but so far we've got a couple of good candidates that have come in, and we're hopeful that we'll be able to continue to get folks on board relatively quickly so that the transition next March will go smoothly. So that's obviously a very big focus area for us right now. Additionally, as we've talked in the past, there's so many security related things, but also compliance related things, mandates that have come down either from the federal government or from the state, things that we need to get done this year on a variety of fronts. And we're obviously working on all of those things to meet those compliance deadlines, but also making sure that we're buttoning up all those areas of potential risk or threat to our organization and our data. And we're making great progress on all of that. And I plan to give you more detailed update on our security and compliance efforts in the future. But that would be the second primary area of focus for the department. The third one that I mentioned is systems management, and that encompasses quite a few things. We didn't really have all the tools that we needed to manage our environment well, and we've been implementing a lot of very good tools right now, which will make it easier for us to support the organization in a much more timely manner, proactively address issues before they crop up and become bigger problems for the organizations and so on. Handling upgrades and making sure that we can report well on what's going on out of our systems, and just doing life cycle replacement of equipment, making sure that our equipment isn't aging too much, that it's able to keep up with the computing demands necessary for the organization. So a lot of different things that kind of fall under system management that gives you a flavor for the different pieces moving in there. Then the last one I mentioned was processes. So again, it's really formalizing some things that we were doing, but maybe didn't really have a well organized, and other things that we weren't doing at all that we're doing now. Project management, change management, quality assurance, and even bringing some tools in to help make that process more consistent as we execute those different processes to make sure that what we deliver is of good quality and is done consistently and to meet expectations going forward. So those are the 4 things: staffing, security and compliance, system management, and processes that we are heads down as a department working on right now. And I feel that they're all making good progress. So there's my brief summary of the IT related activities.
Thank you, Brett. Any questions? All right, thank you. Facility update, Tim.
Yes, thank you. Good afternoon. I'd like to start by welcoming Brooke Todd to Whidbey Health. She is a Sodexo, works for Sodexo, is overseeing the nutritional services in the dietary department. She was hired. They were finally able to find a replacement for Connor. We had one other individual, very briefly. She had a hard time finding housing. Luckily, Brooke, already living on the island, has a lot of experience and is doing a wonderful job and fitting very well. So I'd like to just introduce her, welcome her to the team. If you get a chance to say hello, welcome her aboard. Other things, we have completed the move to the new, the women's care, moving into the Coopville Clinic. It went very successful. Staff are doing great over there, very happy. I think physicians are very happy with the space that they currently have, and parking lot's been full, so it's doing really good. Jake and I and Ron right now, we're working on trying to possibly look at holding on to where the women's care was, and possibly to look at renewing that lease, but at a reduced rate, so that we could possibly move surgical services in there and reduce that cost that we're paying for that building. So we're working on that. Some very positive news. As some of you are aware, I've been working with Apollo Mechanical. I brought them on board probably about 1.5 years ago. The state of Washington requires us to reduce our energy usage. And so we want to take advantage of any grants that we can, because we do need to update a lot of our infrastructure. It's 30 years plus old. A lot of stuff is past end of life, well past end of life. We've been experiencing a lot of failures as of late. We have a couple air handlers that are down and need some replacement. We have a compressor being crane lifted onto the building tomorrow morning to fix one of the units that serves the kitchen. We have a unit that serves the lobby that we have to replace, kind of an emergency situation. I received a couple bids, but we'll be replacing that. But we've been, as part of the plan, trying to, put something in place so that we can get some help in paying for some of this equipment that we need to replace and relieve some of that infrastructure that would be involved with the USDA loan, so that we don't have to use as much, or we could free up some of that money for other things. And as construction costs continue to rise, we may have need every bit of that we can. But we did receive 2 grants out of 3 that we applied for. One was the Sunderland grant and the amount of $500,000, and we did receive from the legislation another $550,000. So a little over $1 million that we have to put towards replacing the chiller, which cools the building, mainly serving the ORs and other parts of the building. And then our boilers for heating and hot water, and a couple air handlers. Right now we're looking at, we just got a cash flow. We're trying to finalize what portions that we will be able to do and get that going. So very excited that we did receive that support from our legislation and from the organizations that do hand out these funds. We will be looking at applying for some more grants in the near future that are coming up around the end of summer. We also be receiving a little over $200,000 in incentives from PSC for doing these projects also. So a lot of good news that we can finally start updating some of this equipment before we have major failures. We are pharmacy, the community pharmacy, We're looking at possibly a mid-July for a soft start opening. I know that Reese has been doing a lot of work on the exterior of the building. The building's been painted. They've been doing some reframing of the columns and trying to make that building look as nice as possible for when we do finally get that open. I know that Cardinal's working very hard to get everything in place so that we can get opened as soon as possible. As Aaron mentioned, right now we have plans into the state under review for the seclusion room and for the floral. We finally got to that point. We had to go through a long process to get the cost of the equipment for the floral room not included in our permit fee so that we could pay a smaller permit fee for that plan review. That finally got approved. And so the drawings are submitted. Hopefully we'll get those drawings approved in the next few weeks. We have did receive bids on the seclusion room, but with the same companies are going to rebid the job and combine the floral and the seclusion room together. It'll kind of help save some money if they can come out in one shot and hit both areas at the same time. EOC. So EOC has been doing a lot of work on our workplace violence and our security. On the 21st of this month, I will be having Eric Gutzweiler out here to do a site survey for safety and workplace violence to see some of the things where we have progressed. The last time he was out here, he's with WISHA, but the last time he was out here was prior to COVID. So we're looking forward to having his site visit to see the things that we have been working on with care. On June 8th, myself and Shanna will be joining a webinar. There's to review some of the new Washington regulations that are overseeing workplace violence. So beyond that, that's my update. If there's any questions, I'd be glad to answer them.
Are there any questions from the board? Seeing none, thank you, Tim. That was great. Appreciate it. And, Debbie too.
No, Debbie will be next.
Yeah. Mr. Tellis is throwing.
I know, I'm throwing you a curveball. Sorry.
Anyway, thanks, Tim, and keep up the good work. Moving on to Debbie with Human Resources.
Good afternoon and happy Nurses Week and Healthcare Week. Nurses Week, we actually started celebrating towards the end of last week. And of course, that will end on Florence Nightingale's birthday and also Healthcare Week. So that's a nice lead in to talk about some of the people in the larger HR umbrella, employee health and education and marketing, which has had an awful lot to do with helping us celebrate this week. And then the inner HR core team. And to explain all the big flowers, today happens to be April Showers Bring May Flowers, Hawaiian wear, etc. So happy Nurses Week, and especially to Erin, to your group, and all the great nurses. So employee health, we have had 36 days without an injury and only one workers' comp claim, and one near miss was reported for the month of April. And we'll go to the next slide. We'll talk about the fact we have an exposure assessment survey underway, actually kicked off April 26th to department leaders as a preliminary look to identify departments that have potential exposures to chemicals, hazardous drugs, bloodborne pathogens, and respiratory hazards. And so just part of a regulatory requirement to determine positions with exposures and determine what controls, if any, are needed. The exposure control plan for blood and other potentially infectious materials has been revised, but we're just awaiting the results from the survey we just talked about before that can be completed. And there have been some complaints of periodic propane odor from the kitchen and the West Wind Cafe. So facilities is checking out the propane line for connections to make sure there aren't any leaks. And employee health is assessing if additional industrial hygiene survey needs to be performed to determine other potential sources and exposure levels. And we're really lucky that our employee health staff happens to have an industrial hygiene background. So Derek is all over that. And then when we go to marketing, We'll talk about some of the campaigns currently in the market and where we're at with the walk-in clinics. The total joint replacement continues to be a primary focus for media in the market. And assets have already been developed and have been slightly retooled for specific ongoing utilization across the various print and digital platforms that are being utilized. And we're still pushing to grow awareness of the walk-in clinics, specifically the fact that they're available on weekends, if you didn't know that. And Connor has wrap cards that are on order that will be hand delivered to affiliated and non-affiliated providers to grow awareness of our walk-in clinics. And Total Joint is a new service with full assets developed, continuing to promote and drive that business. There's a business focus in the coming months for the community pharmacy. The soft launch is to be determined. Grand opening also to be determined, but we're closing in on that. Marketing assets have been created and some great photography was just happening last week with some staged shots and for various marketing collateral, both print and digital. And the campaign's changed from its initial design. It'll now correspond to the soft opening for an unknown period of time, so stay tuned on that one. And women's care and rehab is also going to be a focus in the coming months. So there's some entrance points and revenue making service lines for new patients. And then the Pulse, our digital and some print copy magazine, has been made and it's being distributed to town and city libraries with great reception and success and prominent senior centers. And this is going to continue each month going forward. That was actually at the suggestion of Commissioner Kammermeyer. Thank you very much. It's been very well received as it's been distributed. And so each month marketing will report out regarding the reach of distributing by those means. And in addition to highlighting employees and providing updates from our CEO and commissioners, the Pulse serves as a long form connection to the community. So the Pulse each month will work towards illustrating exactly how large we are in regards to the variety of services and the care that our community can be provided without having to leave the island. And when we look at education projects and practice change and improvement support, so as policies change and there's a need for support, they've been busily working new education programs such as the CHESS certification for EVS techs. So the EVS techs, they have a pathway to a clean course. And so this is a 4-part course that's been designed specifically for our EVS techs. And it's another way to develop and really elevate the staff and improve the quality of work that is being done at Whidbey Health. There's also some diversity training. It's in developmental stages and it's going to be included in new employee training. And there'll be an annual compliance component for all staff. So you can look forward to that coming out soon. When we look at the initiated test out function, so whenever possible, there's creating the option to allow students, when you're taking our health stream coursework, to take and pre-test. And if we pass at a high level, the course will be marked off as completed. And otherwise you can enjoy going through the coursework. Quality improvement. So every quality improvement requires education and training. And so just some recent examples include patient belongings, drug diversion, fall prevention, and patient safety companion. And as for our student processes, so since the implementation of March 15th, we've had 15 requests for clinical placement by students in a program and accepted 12 of those during all of April and through May. And included in that are nurse practitioner students, medical students, RN students that are in their last experience before graduation, job shadow for pre-med students, healthcare leadership students. And 3 of these happen to be some of our own staff that are advancing their career. So that is fun to talk about. And going back up to the first bullet about, oh, sorry, no, it's okay, we can move on. Clinical orientation and redesign. So accommodating the faster onboarding with the mini HR orientation. So we, at the beginning of each month, have a full day orientation, but in an effort to bring employees on quicker and throughout the weeks and months, we have designed a mini orientation, and clinical orientation has also been redesigned and is partnering very well with our overall new hire orientation. So they serve all RNs and CNAs and techs in the hospital, and it's based on roles to establish competency of core skills, and there'll be return demonstration. And in this picture on the left, we have Cindy, who is one of our clinical educators. Then when we go to the human resource team slide, we have been working, dashboard. So we have year to date had 100 terminations of employees. Our turnover rate is just over 12%. And the average service time here is just over 6 years. And you can see in the graph how it's broken out now. The reduction in force is still the large segment of the pie so far this year. That slice will get smaller as the year goes on, and you can look across that and see, resignations, temp assignments that ended. Sometimes people choose to retire, or probationary period doesn't work out. So we're continuing to deep dive and analyze that data and have a growing bank of exit interview data where people have been very kind to share with us some of their best experiences at Whidbey Health and identify some opportunities and areas that we can grow or watch for patterns as that data is coming together. So that is the update there. Now to go to the last slide. So provider recruiting, we have been busy filling some slots for Cabot. People have had to wait to get a new provider at Cabot, and we are working on bringing in 3 amazing providers are actually in the queue now with various estimated start dates in the next 3 months. And also women's health has a focus in our recruiting efforts, as well as organizational wide recruiting. We're happy that we're starting to have some openings. It's well timed with having to end the service line of home health. There are some professionals that are looking at other internal positions. And so that has been great. In fact, today we're partnering with home health and having kind of an open house, meeting them where they're at and going across the street to home health and working with the employees to answer any transitional questions or help them understand which positions are open and talk about those things. And education department's been supporting new employee orientation, and we're continuing to revamp, and we'll be rolling out a finalized new product here in the coming months. The education manager, Christy Stevens, has taken a very active role in that part, and in fact will help lead some of the orientations as we're buttoning up the changes before we hand it back over for onboarding and orientation facilitation. Patient experience, we heard a lot about that with John. Of course, we're partnering on that, a real customer service oriented focus and working through the steps. I probably don't need to go into that anymore. You covered it so nicely. And labor relations, we have some ongoing negotiations. And so none to be able to speak to is being finalized today, but a lot of movement there. Are there any questions?
There you go.
I have a question regarding the transition to Eden. Now I understand that they were supposed to be willing to take all of our people.
Yes, they actually offered, they had a blanket offer out that they would make a room for any employee that would be transitioning out of home health. And so everybody was offered a position, even positions that they didn't actually have. They offered to make a position so everybody would. Unfortunately, not everybody has wanted to apply for those positions. So if some employees may not choose to go to Eden, some have applied, for example, to another option signature, some are taking internal positions, and some may choose to exit the organization altogether with the independent plans.
And we really won't know what those final tallies are for about another month or so, right?
Correct. I'll be able to report next month.
Okay, great. Thank you.
I think it's important to emphasize too that if there's not, Eden isn't buying our business. We haven't sold anything to them. This is really, we've divested ourselves of the home health service line. And as a community partner, Eden has offered to pick up patients, assist in the transition of care. And they've also offered to pick up staff. But we don't have any type of formal agreement between Whidbey Health and Eden. I know there has been some question about that. In our letter to patients, we've given them both options. There's Eden and their signature on the island, and we're very grateful that Eden has offered to be a community partner. But yeah, I just want to make sure it's clear that there's no formalized arrangement or agreement between our organizations.
Thank you, Jake.
Any other comments or questions? Thank you, Debbie. It was great. Before we move on, just so I can give Dr. Miller a little bit of time, we should have had him on the agenda, and we'll put him in there right after Kevin is done. But Dr. Miller, I just wanted to give you a few minutes to kind of be prepared that we're going to call you out here in a minute. So didn't want to just drop a bombshell on you. And I did forget to mention that when we are done with the administrator's report, we will be going into executive session. And I'll announce that and all that part of it, but I just want to make sure it's on there. And the other one was there was a correction on our agenda today that our next board meeting is June 9th, not May 12th. So at the very bottom of the sheet, if anybody's wondering, our next board meeting will be on the June 9th. So anyway, now we will move on to Jennifer. What's that?
Wasn't that also in person?
Yes, but it's basically, it's going to be just the board. It's not going to be open to where the public can come yet.
Okay.
We can only have a small group together. So it'll just be the board and a couple of, admin people. But like I said, it'll be a small one. Hopefully in July, we can get back to a little bit more towards normalcy and have it open to the public.
And for clarity too, if the meeting does take place in person, it will be a hybrid. So while the board members may be present, there will be a remote option for the public to be able to log into.
Correct. Okay, thanks, Jake. We'll move on to our finance update. Jennifer.
Yes, hello. Thank you. I have slides here. Okay. Okay, so March is the one I wanted to talk about last month. So you can see our admissions for inpatient utilization is up, projected to be 2% over our budgeted target, although that will even out over as we go throughout the year. You can see the babies are the admissions that are bringing us so high. Although if you look at patient days, they're really staying longer in med-surg and the ICU and not staying quite so long in the birthplace. But still our total patient days are projected to go 10% over budget. Although again, that targeted projection is really based on what's happened so far this year. So if it were to continue as it was, that's where we would end up. I can't see my monthly over here, so I'm going to move the picture over, and you can see that month over month, I added April because I wanted to talk about April, but we have March financials. So I just wanted you to have both to reference. Month over month, April is actually high in admissions, although I'll talk a little bit about how April's shaping up to be not quite as good financially as March. So if there are any questions about that, I'm happy to answer. Otherwise, we'll go on to the next slide. On outpatient utilization, our ED visits were up in April, still sliding in March, and projected to be about 19% under our target, which is consistent with our neighbors especially in the collaborative. They've all reported that their emergency room visits are down. We thought maybe those visits were going to the walk-in clinics, and I think they are a little bit, but we're also picking up new patients at the walk-in clinic. So that's good news. You can see surgeries are doing quite well. We can't really compare April to April because that's when COVID hit us last year. So, but still we're about even with our projected budget. MAC volumes are up. Sleep center down, mainly because we've been lacking a nighttime tech in the sleep center, so there haven't been any nighttime studies happening. Home health and hospice a little bit down. Any questions about that? Or any you'd want to see moving forward? I just pick them. So our clinic activity, you can see overall, everybody was just a bit down in April across all of the specialty care and primary clinics, but still doing pretty well. March, again, what we're going to look at the financials was really busy at all the clinics. Next slide, please. And then our walk-in clinics, you can see they're doing pretty well. I did put a break even here of 390 visits for the Clinton walk-in. That's based on how many providers they currently have right now, staff. Same thing at Goldie. They're making progress, remembering they've only been open less than a year. So, so doing quite well, I think. And they're also starting to make a few little scheduled appointments at the walk-in clinics for follow-up appointments from the ED, sort of taking some of the pressure off Cabot in particular. So I think they're making a few little changes there to make the activity a little better. And then the thing that I'm very happy about and to report is our total finances in March. We had a whopping, and we haven't seen this for a very long time, but a nice profit of $1 million before depreciation. Bottom line, just under $1 million, 720, which actually brought us year to date better than budget. Although, as I said, April's not coming in quite as good. We're working to close April today. Going to probably see a little bit of a loss in April, but still pretty consistent with our budget. So the thing that really helped us here is our gross patient charges. I don't even remember when I've seen gross patient charges that high, and it was just a lot of, I think, charge reconciliation, making sure that we have everything in. There were a few little late charges, but wound care service was about, I think it was about $500,000 over budget. So that was helpful there. So they're doing great in the wound care. What else can I talk about here? I don't know. Are there any questions?
I don't know whether to ask you or not, but going back to the consent agenda.
Yes.
Is the work that has been going on in with Kevin and the work that you're doing with Beth and everything, is that reflected with any changes in the consent agenda itself? Because the total adjustment now is like almost 400,000, but I think it used to be higher.
I'm not totally sure which part of the consent agenda you're talking about. Are you talking about the bills paid or?
Well, I'm just sort of wondering, you know.
It's a lot of the, it's Jennifer, it's a lot of the write-offs. I think it's a segregation of
write-offs.
Administrative write-offs. And so I saw that too, Greta, that's one of the lower months that we've seen in a while. And it may be, and maybe Kevin, when he gives his discussion, talk about how he is focusing on the denial process. But yeah, I have seen a reduction in that. And it may be maybe once a year or twice a year we go through, instead of putting in a consent agenda, put it for a discussion. That might be another opportunity for us.
Yeah.
Sorry, and I do know that they talked in finance, we talked about how we're going to measure that progress in the denial area, and Kevin's new spreadsheets, I think, will address some of those questions. Any other questions?
Jennifer, can you update us on cash on hand?
Cash on hand, we received this week our levy dollars. So our cash on hand currently is at 4.6 days in the positive.
And last question,
Yep.
I assume since you didn't say anything about it, or maybe Ron's about to, that we haven't gotten the FEMA money yet.
So I can talk a lot about FEMA. And I gave, I think, a pretty extensive update in the Finance Committee, but FEMA seems to be a little bit of a moving target for us as new CARES Act money comes available for application, for just distribution. I'm finding I'm having to go back and peel away some of that grant request from FEMA. So now we have separately our public health district FEMA money, which is coming. We've billed them $350,000, I think, and about ready to bill another 500,000 or so. Then that $1.6 million in the second FEMA grant. Now I'm also pulling back some of the testing expenses for that, because that will actually come through CARES Act money that we're about to get $500,000 for testing. And another grant that will come from CARES through the state from our SHIP, because we participate in the SHIP grant, we'll be getting another about $100,000 from that. That also has to peel off back away from the FEMA monies, because we just can't double dip. So we got to make sure that we're not double dipping on any of that money. So as the CARES Act money comes, we pull away, because it's much easier to get and jump through the hoops of the CARES Act than it is the FEMA dollars. So I'm not exactly sure where we'll end up in our next phase of our FEMA grant application. I think probably around $700,000, because we'll be getting the other $900,000 from CARES Act money. So short story long, it's a moving target.
And no indication about timing of receipt of any of this.
Well, as I said, the CARES Act money comes faster. So I'm expecting within a week or so, probably, that first round of round 3 of the CARES Act money, which will be about $500,000. That's for testing. Then there's a piece we have to actually apply for. The application isn't open quite yet, so we're waiting for them to open the application for that. And then I'll see what that entails and what piece of the FEMA money we should apply there for. So timing is, I'd say the more we can take away from that original FEMA grant, the better, because they're just stretching it out as long as they can.
Okay, thank you.
Yeah. Any other
Is there
questions?
any other questions? None? Thank you, Jennifer.
Thank you.
We'll move on to Kevin for our strategic planning update.
Thank you, Commissioner Wallen. All right, so let's dive in. So one of the things that we're right in the middle of right now is strategic planning. And the purpose
Kevin, we always seem to have trouble hearing you.
Let's see, I probably better call in then. Give me just a moment.
To talk to Brett about a new computer.
Yeah, I know people.
Kevin, are you going to call in or are you going to?
Yes. Yeah, let me call in. I'll be just a moment.
All right.
Kevin, while you're doing that, we'll go ahead and move on to Dr. Miller to keep things rolling.
Sounds good.
Dr. Miller, you're on. We'd like to get a little update of the patient clinics.
Okay, well, thank you for allowing me to participate. Just a quick educational update. There are now 10 Whidbey Health outpatient clinics. They include 5 rural health clinics and 5 specialty clinics. The primary care clinics in Freeland and Cabot, 2 walk-in clinics, one in Oak Harbor and the other in Clinton. And specialty clinics include women's care, orthopedics, general surgery, and sleep care. And then there are the 2 MAC clinics, the medical ambulatory care clinics, the oncology clinic, and the wound care clinic. So some of what I was going to say has already been covered by the other folks here today, but in primary care, Cabot has had a reduction in the providers over the past year from 8 down to currently 5. But as you heard from Debbie, we are actively recruiting 3 ARNPs and hope to get them working with us by this summer. So that's very exciting. We've had trouble in Cabot with the phone system. It started when all of the clinics consolidated with COVID. And it's been largely rectified, I'm happy to say at this point, with new service lines being installed. And we're having better results with fewer people abandoning their phone calls, and the phone agents are answering many more phone calls than they did before. We also have almost completely restored the voicemail functionality in all of our 10 clinics. Freeland is doing very well. They have 3 providers and they're getting increasingly busy. Cabot has been closed to new patients because of their short-staffed provider situation, but Freeland is seeing at least 5 new patients every day, and they are getting quite busy. Things that we're doing, the work's in progress. We're hoping to provide more diabetes education in the primary care clinics. Aaron and I are talking about moving the palliative care program into the clinics in one location or another. The walk-in clinics, the volume is progressively increasing. From the data that you saw from Jennifer, we saw over 1,000, there were over 1,000 visits between the 2 walk-in clinics last month. And part of that is due to working together to offload some of the urgent and emergency follow-up patients that formerly would be seen in the primary care clinics. They're now being directed to the walk-in clinic. So when you're sitting in the emergency room and you need urgent follow-up in a day or 2, they're going to the walk-in clinics. The hospital follow-ups are also being seen in the walk-in clinics if appropriate. And then the urgent patients that want to be seen on very short notice, if there's no room in the primary care clinics, they are also being directed to the walk-in clinics. And that seems to be working well. There was an issue about price transparency in the walk-in clinics, and I think we've largely addressed that with better signage, better communication. We now have a sheets that we can give out to the patients in the walk-in clinics that are uninsured, so they know what the cost of the service is going to be, both for the visit and for the most common laboratory and diagnostic imaging services that are provided there. We hope that that will be a patient satisfier. In the specialty clinic area, you heard Debbie mention about the total joint program that seems to be doing well right now. Connor has created a tremendous video that I believe is about to be released to the website and several other places that really highlights Dr. Addition and the total joint program that we have now here. Women's Center, we are trying to recruit another provider, a third full-time provider, as well as some locums coverage for the summer. In general surgery, we're about to launch a per diem general surgery program where surgeons from outside our institution can come and help cover us to provide some relief for our general surgeons that take call every third night and are frequently very busy. And we're hopeful that that will be a successful program. The wound care program is a new provider-based program. It's been up and running for less than a year now, but is getting quite busy, and we're introducing new techniques, including new skin substitutes, and we've started the process of building a quality dashboard to track our outcomes, and there'll be more to come on that. Speaking of clinic quality, we have quality metrics for all of our clinics now, except for wound care, which is currently they're being established. We have them for the orthopedic clinic, and we're collecting baseline data, and the primary care clinics all have quality metrics. And the walk-in clinics now also have quality metrics that we are tracking. A new quality metric that we just started tracking is wait times in the clinic. We know that that's been a patient dissatisfier, so we're now starting to track that. We'll be tracking that by clinic and by provider and see if there's ways we can improve that efficiency. Other things that are coming that will relate to patient satisfaction, and also one of the questions that was posted. There are several upgrades to our electronic health records that our primary care clinics, and actually all the clinics, are using, with the exception of the hospital-based ones, the Athena Health program. Several upgrades are coming, one of which will help hopefully improve the turnaround time between when our providers order a diagnostic imaging test and when it actually can be performed. That upgrade is going to happen this month. In July, the electronic medical prescribing upgrade will occur. That will address one of the questions one of the attendees asked about prescriptions and refills. This should help speed up that process dramatically. And then in August, the controlled substance prescribing software upgrade will also be implemented, so that at that point, every single prescription that our providers write, both for controlled substances and non-controlled substances, will be able to be sent electronically anywhere. So that's pretty exciting. And then the last thing that hopefully I would like to see happen is a merge between the inpatient and outpatient portals. And I know Brett is working on that to perhaps implement maybe sometime this fall, as well as a online patient registration, so that patients don't have to fill out so much paperwork when they come to the clinic. That's my report.
Well, thank you. And any questions for Dr. Miller?
I do have one question, and it's kind of a detailed question. I wouldn't expect you to necessarily have the answer, but through all this phone change, did the fax receiving line at Cabot get a new number? And the reason I say that, I have heard several people say that their pharmacies have faxed the information to Cabot to get refill authorization, and Cabot says they never got it, including myself. But two of my friends it's happened to from other pharmacies than the one I utilize. So if there's a new number for the fax, for prescription refills at Cabot, that needs to be publicized to the local pharmacies.
So there's not a new phone number for fax lines. I'll have to check and see if any of the additional voice lines that we brought in are helping with this. I know we've got an upgrade that we're doing to our fax platform, but it sounds like it's just the number of fax lines that we may have, or we may not have enough coming in. We might get overloaded and then faxes don't go through. So this is something I'm going to have to investigate.
Thank you. Dr. Miller, appreciate you kind of coming on at the last. I'll make sure that Melanie puts you on our schedule, because that is an important part of it, that we need to have, you know, you involved and giving us a report. So I apologize that it was not on the agenda to start with, and I'm thankful that you stepped in. And Melanie's probably listening in and would make sure that she puts it on the next month's agenda. Thank you. Okay. Kevin, are we back on?
All right, so I dialed in. Can you hear me now?
Definitely.
Yeah. All right, golden. Okay, so at the beginning of 2020, the executive leadership team set a strategic focus, so 5 areas of focus. But since that time, we have a number of significant changes, the most important of which is 4 new members of the executive leadership team. So John Scallon in quality, Debbie DeCourty in HR, Brett Mello in IT, and Dr. Miller in the clinics. And with an executive leadership team like this that brings great experience from a variety of different cultures and areas, it's important that they are all on the same page, that they all have the same strategic focus. And so we're right in the middle right now of that strategic planning. So we brought that team together, and we are taking a longer term outlook than we did in 2020. We're looking at a 5-year window of time and reviewing vision, mission, values, and what the highest priorities and objectives for the organization are, so that we're able to make sure that the actions we commit to at this time are consistent with a longer term vision and plan. So the team is right in the middle of that right now. A lot of the focus is to make sure that we give our patients a better experience, also that our employees and our providers have a better place to work, and also that we as an organization are on sound financial footing. And there's a lot that has to be adjusted just to accommodate the new reality coming out of COVID-19 and where we find ourselves. So this includes a lot of work on our financial reporting internally, and making sure that we're keeping our eyes on important goals and milestones. So hence the aligned financial scorecard, which would be a tool used by our executive leadership team and also the board to make sure that we are tracking against our goals. And as soon as we've got this strategic plan in place and ready to go, the next step, of course, would be to roll that out to the rest of the organization to make sure that they are aware of what those objectives and priorities are, and any refresh on the vision, mission, and values. Next slide. Another key thing that we are working on is our denials management. We implemented a few months ago the use of a denials log. And the purpose behind that was to make sure that we had better view or vision of actual denials, the denials that we call preventable, things that happen that if we change what we're doing on the front end, should be able to affect those. So we're also seeking to strengthen ties and the level of coordination between our coders and our billers, as well as giving tools and reports to some of the key departments that have a lot of volume and have a significant effect on those denials. So laboratory, diagnostic imaging, our emergency department, the MAC or cancer center, and also our patient financial services. Make sure that they are tied together and that they're working closely together. So it's important to note that denials are a normal component of healthcare, and every organization has them and strives also to improve their performance around them. We put a lot of work into this last year, and while the rate of denials did not decrease as much as we wanted to see it decrease, we also discovered in hindsight that the rate of denials throughout the nation has been climbing, and particularly here in the Pacific Northwest. And so while we ended up the year at 11.6% on our average, here in the Northwest, the average was over 13%. However, those who are really good at this have a much lower percent. And so we know that it's possible to have a much lower percent of denials. So we are pursuing that. And a lot of that is monthly meetings that are set up between some of these departments and HIM and PFS in order to coordinate the denials that are taking place, make sure that they have good information on the front end, and can reduce that on the back end. There are a few other key things that I'm focused on, mostly around performance improvement and process improvement. Most of those tied to our patient experience. So, for example, working with our registrars who are part of our patient access team, and also the emergency department, and also med-surg/ICU to make sure that we improve the patient's experience at the front round and are well coordinated, especially around our visitor policy, that those three departments know how to handle that best, so as to make sure that our patients walking in the front door have a good experience. Also, we discovered that sometimes it is taking longer than we want it to when a provider orders an imaging test for the imaging test to be completed and brought back into the provider's hands. And so working with Dr. Miller and our referrals team, diagnostic imaging, and some of our clinics, we're digging into that right now to determine how we bring those times down closer to national averages. So those are some of the key things that I'm working on at this time. And with that, I'll hand it back over and open it up for questions.
Are there any questions from the board? Seeing none, thank you, Kevin. We appreciate this. Is there a comment? Okay, well, I think we'll move on to executive session and skip Roncho. We're going to move on to administrator's report. Mr. Tellis.
Thank you, Mr. Wallen. And I think as you heard from Debbie, that it is Hospital Week, Nurses Week. We kind of combined the two. And as you see, some days we are dressed in floral or Hawaiian. And as you notice, I am in a bit of a Hawaiian, and some of us can pretend we're in Hawaii, while others of us are actually going to Hawaii. And if you take a look at Jake's background, I wonder who's going to Hawaii very quickly. So aloha there, young man, Jake. Tomorrow is Crazy Mask Day. And I think Friday it's Sports Jersey Day, and no, I will not be a Seahawk or type, but you might see me in a Niners. Just saying.
Jennifer, hold this tape for the
but every day is a dress day. Every day there's gift cards being raffled off, whether it's Starbucks or Safeway. Even once a day there's a Fitbit or a Apple Watch and that's going to end on Friday. And so I appreciate everyone's participation and the Employee Recognition Committee for really stepping up and helping us facilitate that. Because it has been one heck of a crazy year, whether it's COVID, whether it's getting the tests out for COVID, whether it's the vaccine, whether it's dealing with PPEs, whether it's dealing with staff shortages, and hopefully not this year we'll see any murder hornets, but it's been a crazy, crazy year. And really this team of providers, this team of clinical staff, our team of support staff, our team of volunteers really do need a thank you. And I've seen this last year. I am humbled by how passionate they are of doing this great work and to keep our patients healthy and our community safe. So pretty amazing at that. I wanted to get, and I think maybe every so often we bring Helen from the foundation to give a report. And I know this month is called Give Big campaign. If you get a lot of emails from Boys and Girls Club, Big Brothers, Big Sisters, this is a month where they have a big campaign. It's usually about this time. And so the foundation also is doing this, and they had a goal of 40,000. According to the text I just received from Helen, they exceeded that already. So that is fantastic, and thanks for that. She says year to date, they've received over $650,000 to support Whidbey Health and our mission. So that is fantastic, and I appreciate Helen and the foundation board. As you heard from Tim, I want to reiterate that thanks to the Sunderland Foundation for the $500,000, and also Representative Gilday for sponsoring a legislative bill to get us another $550,000. Again, Tim says, look, we need a chiller. If that chiller goes out, we're closing our shop. So that is going to be our priority, and you will see some renovation construction going on in a couple of months, I would say. And you heard, I think, maybe it was Aaron who talked about the hospice survey, and John did too a little bit about, we had a survey team here for a couple of days, and I gotta admit, when you talked to PC and I went over there as when the survey team was there, the team of nurses who go out to the homes, usually when a survey team comes, people scatter like cockroaches in the sun. Not this. This team was like, hey, I'll be glad to bring them on to a home visit. That's how wonderful they are. And to get 0 issues,
oh yeah,
is
amazing,
unheard of. So really, hats off to that hospice team. It's pretty impressive. We talked a little bit, and I know that some of you have heard attended our medical staff meeting or med exec meeting about Navy, and how unfortunately we really want to partner with our Navy. We want to provide the services here to facilitate their orthopedic surgeries and such. But the Navy has reached out to us to better partner and strengthen our partnership by working together with us and Aaron and their CNO to put together a training affiliation agreement, that TAA we keep talking about. I think that would really be a help, and I think when they reached out to us, we hope there's some motive there to get that done so we can continue that partnership. So I'm looking forward to that. One of the things that and Kevin talked about our strategic plan, and we went off site and we talked about what can we do right now. We talked about 4 seasons and how the 4 seasons leadership does rounding and ask the question to our employees or our leaders of those departments, what can we do for you? What do you need from us? I did my rounding and it cost me money. When I went to HIM, I said, hey, team, their team was there working hard and doing and organizing the charts and such. I said, what do you guys need from me? They said chocolates. So I had to go down to the gift shop. I rounded the gift shop and purchased some See's candy, which is wonderful, inexpensive, $23, and brought it to the HIM team. I mean, I'd go down to either, I think, imaging or lab, and one of our employees has a chicken farm and had eggs. So I purchased some eggs too. So it's actually costing me a lot of money to round, Kevin. I just thought I'd tell you, it's a challenge here.
Donuts are more expensive.
But they're very tasty. Thank you, sir. And then I do want to talk and want to thank our patients who are being inundated with a survey. And it's important for us. And I know John didn't mention it this time, but we have this new thing called Survey Vitals. And I've been a patient of our clinics, and I was inundated with phone calls and emails to accomplish this survey. And please do. It is our way of figuring out what's good and what's bad. And it segregates everything from registration, wait time, physician, bedside manner, for lack of a better word, whether you're an inpatient or an outpatient. And I think it's so important. And I hope that, and if you don't, the board does not have access, I know you could contact John to get access to this. I try to look at it once a week, and I think it really shows some insight to where we can do some improvement. And we talk about patient experience. That's a key to how we know if we are doing the right thing. And so please, board members, I hope you will take a look at that. And if you need some support on logging on, I know Mr. Scallon would be happy to do that. It is a great tool to have. And I appreciate John for bringing that on. And I guess the last thing is, and Aaron talked about how Island County is doing fairly well with vaccinating and not having a hospitalization. Yesterday, St. Joe's over at Bellingham had to stop their elective surgeries and stop doing some surgical cases because their ED was inundated enough that they had to make sure they had the resources to take care of their patients in the ED. And I know along the Highway 5 corridor, those hospitals are being inundated. Hats off to Island County and to our community, but the fourth wave is here, and we just got to continue to wear our masks, continue to wash our hands, continue to be safe. That is really saving us from continuing to be open and to be more, as you see from our visitor policy, be a bit more relaxed. We are doing amazing work here. You've heard this 2-hour presentation, and I know it's a lot, but that's how much your team is working on. And so I appreciate it all. Happy Hospital Week and Nurses Week. And that's anything from me that I can answer.
I think the whole board appreciates all the involvement here. Each one of these reports, we're getting down into what's going on here and how we're improving. It's very important. We appreciate the whole team providing all the information. So is there any questions of Mr. Tellis? Okay, seeing none, we're going to have to adjourn our meeting and go into executive session. I think all the board members have the call-in number, correct?
Yes.
Okay, and then we'll come out. Jake, are you there?
Yes, I am here. So just to specify, clarify, we'll be going into executive session to discuss current potential litigation and the potential sale of real property. And we will.
How long do you think we need?
Probably 45 minutes. I don't anticipate any action being taken at the conclusion of the executive session.
So do we want to have everybody call in like 10 minutes, take a 10-minute break?
Sounds good.
I think from what Jake said, we should adjourn this meeting and just have our executive session. So I move adjournment.
Second.
All in favor?
Aye.
Okay, call back in at 10 after 2. Thank you. Thank you.